I know you're here to talk about the Watchman procedure. One of the things I like to do is just to show an animation and go through the procedure because I think it answers a lot of the questions the patients have. This is the heart, and there's a top chamber up here called the left atrium. Patients who have atrial fibrillation, which is a condition you have, will have the top chamber kind of fibrillates. And one of the things that can happen is you can get a clot that forms in a certain area. That area is called the left atrial appendage. And it turns out 90–95% of all clots form in this same area for patients with atrial fibrillation. And this will show here, if a clot forms, it can then get pumped out of the heart and up to the brain, causing a stroke. So our first line of therapy is to give patients blood thinners. It's not a procedure, and it's what everybody recommends as the first line. However, certain patients may not be good candidates to be on long-term blood thinners. Some of the issues we see are GI bleeding, fall risk. Sometimes patients are really unstable and they don't want to fall on blood thinners. For these reasons and others, patients will be sent to me, referred by another doctor to have this procedure done. And the goal of this procedure is to get patients off the blood thinner while still keeping a low risk of stroke related to the atrial fibrillation.
Am I a good candidate for this procedure?
Yes. So any patient that has a good reason to not be on blood thinners anymore is a candidate for Watchman. And so we will have an independent doctor talk to you about it, and most of my patients that I see will be referred from another doctor like yourself. And it's really a good solution in the long run to get patients off of blood thinners and get rid of the potential to have a stroke.
How do I prepare for this procedure, Dr. Raney?
We used to do some screening tests, a screening test to try to look at your appendage. And what we do in order to see the appendage is what's called a transesophageal echocardiogram. Okay, I know, big word. What we do is we take an ultrasound, and it's about this size, and it goes down where your food goes. It sounds a little barbaric, but basically the esophagus is right next to the heart. So when we put this down, we can get crystal clear pictures of the appendage, and we can look at the size and make sure that you're a candidate. Fortunately, we have an anesthesiologist there, so you'll be totally comfortable, won't really remember it. Procedure takes about 30–40 minutes. Now with the newer generation devices, specifically the Flex device, we can treat almost everybody, so we stopped doing that screening test. Occasionally we may want to do it just if somebody's had some prior surgery or some other reason, but for the most part, what we'll do is just bring our patients in. We'll start the procedure by doing this transesophageal echo. If the anatomy looks reasonable, then we'll go ahead and start the procedure right afterwards. So the first thing we do is we put a small tube in the femoral vein. I don't like the word groin, it's really over here, kind of right above the hip. And that gives us access, sort of like a freeway, to get up to the heart. And you can see here, we can come up into the heart, cross to a very small thin layer, and now we're in the left atrial appendage. And once we're up in the appendage, we can take some pictures. This will show there's a bunch of different types of appendage. It's unique to every person. And we then bring in the device. Now, when the device comes out, we can form a ball, and once we pull back enough, it'll release into its final shape. And I'll show you the device afterwards. And the nice thing about this is we can move this around. So we can recapture it, we can make this new ball, we can push this inside the appendage here, it won't hurt the appendage, reposition it. Once we get it right where we like it, then we can release it, we'll deploy it, and then we'll go through and get a bunch of echo images, and we'll really make sure that we have a good seal, we like exactly where it's at. Once that's done, we just release the device, and it stays, becomes part of the heart. So this is a very important thing, that once we put the device in, there's a fresh material there. And over about 45 days, you get a skin that grows in all around it. So if you were to look down initially, you would see the device. After 45 days, you'd see this shiny skin that totally covers that. During that time period, we need our patients to be on blood thinners because a clot could form on the device. So the first 45 days after the procedure, even though you're doing this procedure because you're not a good candidate for blood thinners, we will need you to be on blood thinners for a certain amount of time. We'll bring the patient back in, we'll do one more transesophageal echocardiogram, sometimes a CAT scan, to make sure that we have a very good seal and good closure. And once we confirm that, then we can back off the blood thinners.
How long does this take?
Usually it takes about half hour, 45 minutes. Had some that have been longer than that based on the anatomy if they're really complicated, but I'd say most of our procedures take about 45 minutes.
How about the recovery, doctor?
So the recovery is nothing to be worried about. It's actually, most patients tolerate it really well. Patients come in the morning, most people walk out the same day about 5 or 6 hours later. Give them a little time to recover from having some anesthesia. There shouldn't be any pain. I never have to give pain meds to patients on the way out. It's a small incision in the femoral vein. I just tell patients to take it easy for a couple days. For most patients, they can do everything that they were doing before. If somebody's really active, I would tell them, hey, back off for about a week and let everything heal. But for most patients, they can go back to doing everything they were doing before they came in for the procedure. This device is made out of nitinol. Nickel titanium was an alloy that they made originally for spacecraft. But we use it in a lot of our medical devices now. It's very unique in that you can squeeze it down and it will pop back to its original shape. So when we put it through the tube, we can squeeze it down nice and small. And when we get it where we want it, we just let go. And that will eventually just sit and keep its shape like that.
Yeah, this is amazing. Whoa. Yeah. Are there any age limits to this?
No, there's really not. Because this problem, first of all, the older patients are, the more likely they're to have AFib, the higher risk they are for stroke. And a lot of these patients are older who don't tolerate blood thinners. It's really sort of a problem that we see more and more as people age. Patients tolerate this very well. So even if patients are in their 90s, they can come in, they do the procedure, they go home, they feel good. So the success rate is generally about 90–95%. There are certain anatomies where it might have a certain bend or something and it just doesn't work for that anatomy. But the vast majority of patients can be treated with this successfully and we're able to get them off blood thinners. If it doesn't work, we're not able to get in, there are other options. There's actually a minimally invasive surgery that the surgeons can do without doing a full sternotomy. They'll just go in and put a little clip on that area. Occasionally we've sent patients for that. A little bit more invasive than this procedure, so we usually start with this.
You come very highly recommended. So tell me, can you tell me a little bit more about your background?
Sure, so I started doing this procedure about 10 years ago when I did my training down at Scripps. We were in some of the original trials, 2 of the original trials with this device. So I've had a lot of experience over the years.
Is it just you doing this procedure? Is there a team involved or?
Absolutely, there's a team. So it's myself. Generally we have a cardiac anesthesiologist there to keep you nice and comfortable. And then I have a partner who does the transesophageal echo, Dr. Thomas Kim, and he will get all the images and work with me through the whole procedure, figuring out the size, where we want to go in order to get to the appendage. Our staff during the procedure is amazing, and then afterwards, the post-op care, all the patients who come through here, they really are excited, and when they see them back, they say, hey, we had a great experience. Love the staff over there. The St. Joseph program, the Watchman program, is the highest volume in Orange County, and with this high volume and experience, we get better outcomes. The whole team at St. Joseph's is terrific, and patients are very happy with their experience.